Welcome to Module 5. This is the advanced cervical component of the Haynes method of neuromuscular dry needling, the hybrid dry needling certification. If you're in Module 5 here, you're aware of the content and the format. The lecture is provided online. It's provided live if you choose to watch there. But we've gone through the first 4 introductory lectures and modules, and now we're moving on to modules number 5 through 16 of all of the advanced content. Here we're going to be dealing with the cervical spine. As you can see, there is a lot that we're going to deal with. We're going to try to get this all done inside of 2 hours. That is a lot to cover. We'll try to be efficient with our time, and so we'll move on. We're going to do as much as we can through video content so that it can save some of your time for reviewing the slides and so forth at a later date, but that is going to be on the student portal as well. But let's get it started here. One thing we're going to introduce here is in our clinical decision making is a 3-dimensional kinetic screen. So what is this? It's a tool designed to examine complex movement patterns in the body to locate areas of asymmetry, movement dysfunction, and pain. It's patterned after the functional movement screen by Gray Cook, which is designed more for the athletic population. Here, the 3D kinetic screen is appropriate for all age groups and all ambulatory levels of activity. The 3KS is made up of a battery of 11 movements, which are cervical linear motion, cervical diagonal rotation, trunk rotation, lumbar linear motion, lumbar diagonal rotation, figure 4 sitting, shoulder posterior external rotation and internal rotation, the single leg stance on the right, sit to stand, quarter lunge, heel and toe walking. So for the cervical spine, we're going to look at basically the first 3 components here: the cervical linear motion, the cervical diagonal rotation, and then our trunk rotation. In reality, the entire screen should be performed to completion to determine the effects of movement in one body region on other movement systems. At the conclusion of this course, you will have all of the elements in place to perform the entire 3KS 3D kinetic screen to identify painful and abnormal movement patterns, which can be treated and addressed through dry needling. So we'll start by just taking a simple look at these first 3 components. First will be our cervical linear motion. We're going to do 1, 2, 3, 4, 5 repetitions. We'll move on to our cervical diagonal rotation. We'll go, in this case, from the low left to the upper right. And again, we're looking for quality of movement. We're looking for any sort of asymmetry in left versus right. We're looking at postural issues, and we want to use this to help identify any issues that could be going on, and we'll make an assessment of what's happening based on that. Several things of note. So lastly, here is a trunk rotation. Here we want to look at quality of how far the body can rotate side to side. It is your instructor that is performing these, and I will tell you that I do have cervical issues in my cervical spine. I do have a little bit in the thoracic, definitely some in the lumbar. Now we're going to look at it from a side view. Again, you want to look at the quality of movement here. You also want to compare it to what normal would be. Is this what you would expect out of normal type of movement in this situation? Okay, and then we'll look at it from the right inferior to over the shoulder. So here we're going from the armpit up to looking in a diagonal over the left shoulder. And again, trunk rotation from that position as well. So just watching myself perform this, I definitely see several issues. Most notably, I carry my left shoulder higher than I do my right shoulder. I do have limited cervical extension, and my quality of movement from in the diagonal from the armpit up to over the opposite shoulder is notably significant. The carrying the left shoulder higher, I've had broken collarbone on that side. Didn't heal, so required ORIF. I did go through a period of time where I kept that shoulder tucked in extensively during that 4-week period where it was not healing. I do still have some tightness in the muscles over on that side, and at this point it's more of a postural issue. If I were a great patient, I could work on that and make some improvements, but like many of our patients, I'm not always the best at doing that. So that is the cervical piece of our 3KS. So we'll start in our axial spine, our cervical posterior spine. We'll look at our splenius capitis, and this is everything that we looked at in our introductory modules 1 through 4. Here we have, except for the addition of a couple more here. So we'll walk through these. Splenius capitis and cervices, and then the rectus spinae group, spinalis cervices, longissimus and iliocostalis cervices, and then back to semispinalis capitis and cervices, and then the multifidus and the rotatories at the lower, at that cervical and thoracic junction. So we're going to have our surface anatomy and our 3D anatomy through our video presentation. So similar to previous modules, this information is here available. It will be available in the slides, but I'm going to move down to our video presentation on this. So let's look at the three-dimensional anatomy of the cervical, the posterior cervical spine. Now, in the earlier lectures, in the introductory information, I think it was lecture 2, we went ahead and talked about most of the three-dimensional structures in the posterior cervical spine. What we added, what we did not include, were some structures here on the lateral. So here what we're talking about is the longissimus, let's see here, kill that. All right, longissimus coli or cervicis, and then the iliocostalis cervicis or coli. And we didn't deal with those previously. So you see there, so for iliocostalis, origin is off the angle of the 3rd to the 6th rib. So its origin is down low on the rib cage, as well as longissimus. Let me bring that one up. So longissimus, again, here the transverse origin is the transverse processes of T1 through T6. So we've got some distal thoracic origin for these muscles, but the interesting part is where they attach, or where they insert. So as I move here, I want to take a really close look. So as you can see, they attach to the articular pillar. So if we were to try to use dry needling for these small muscles on the thoracic rib cage, it would be rather challenging, and because of the location, probably not recommended due to the location of the danger zones here into the lung field. But as we look, if we take an approach targeted towards the articular pillar on the lateral side, makes that quite a bit easier to draw a needle to. And so we'll include that in a lateral approach, where we'll also include the posterior and the middle scalenes. So we're going to, similar to how we had at C6, spinous process of C6, we covered a lot of the musculature here, similar to spinous process of T4. In that case, we were able to get the distal fibers of, if I can get it to pop up, of the splenius cervicis here. Now we'll actually be able to in theory, be able to needle through that muscular tissue on the lateral ridge of the cervical spine. So that is our three-dimensional anatomy of posterior cervical spine, specific to longissimus and iliocostalis cervicis, that further erector spinae group. All right, so onto our surface anatomy, our palpation lab. Again, a lot more information than we absolutely have to go through here, but let's come down to our video piece and have a quick review there. So let me close that out. Try that again. All right. So first we'll look at it on our 3D anatomy, and then we'll look at it on a live subject. So we'll start by taking a look at our surface anatomy of the cervical spine. We'll start with some anterior structures first to give us a point of reference for identifying posterior structures. And so let me bring up my pen. The structures anteriorly that we'll look at first will be the hyoid bone. Second, we're going to look at the V-notch of the thyroid cartilage. Thirdly, we'll look at the smooth lateral surface of that thyroid cartilage. We'll then look at the cricoid cartilage, and then lastly, the sternal notch further distally. So these would be our anterior structures. Okay, so let me clear that, and let's look at it from a lateral aspect. So how these are going to correlate to our structures posteriorly, the reference is going to be a little bit from a anterior inferior to a superior posterior angulation, simply because of the cervical lordosis that we have. But if you place your hand underneath the mandible, underneath the jaw, and let me drop that down just a little so we can see everything here. Okay, so there we are. So we look at hands underneath the mandible. You can have your subject swallow. You'll feel that hyoid bone move. That's going to have a direct correlation with the spinous process of C3. My line is not exactly straight, so let's try that again. Here we go. There we go. So there we have C3. The V-notch of the thyroid cartilage, and these are all palpable, you can palpate them on yourself, is going to orient to C4. The smooth surface of the thyroid cartilage itself is then going to align with C5, and then further distally, and it sits right about here as a smaller, harder structure, the cricoid cartilage, and that is going to orient to spinous process of C6. We drop down a little further distally, again, the sternal notch sitting right here at the junction at the upper end of the sternum, the manubrium, where that's orientation will be relative to the spinous process of T2. Okay, so let's look at our surface anatomy from a lateral aspect. Some structures we'll be interested in here. Number one will be the mastoid process, just inferior to the ear. We can palpate that. Excuse me. Just inferior to that will be the transverse process of C1. Another structure of importance, especially as we get later into our course, will be the lateral arch, our laminar arch. And so that's on most people, that's fairly easily palpable. It can be tender, especially if someone is having some posterior lateral symptoms, but that is going to be an important landmark for us to discover a little bit later. So let's move from here. Let me clear that, and we will move posteriorly now, and let's evaluate some of our important landmarks here. So let's start first with the external occipital protuberance, easily palpable in this area. There are then going to be three lines of importance, really two, but there's three here, so we'll discuss all of them. First is the supreme nuchal line. Adjacent to the external occipital protuberance will be the superior occipital protuberance, and then further distally and much deeper will be the inferior nuchal line. So supreme, superior, inferior nuchal lines. Let's talk about the spinous processes posterior. C1, rather difficult to palpate if it can be palpated at all. Most commonly, C2 is our first spinous process that we can palpate. We can follow by palpating in between each spinous process and interspinous space to find each of the subsequent spinous process. Of importance, we get down to C5, C6, C7, T1. Then we want to know, okay, well, how do I know if I'm on here? So the easiest way between C6 and C7, a person that's 40 years of age approximately or younger, when you extend the neck, C6 is going to move anteriorly, and then as you extend, it's going to come back to a normal position. C6 does tend to sit a little bit more anterior than C7 to begin with, but in a nice seated position with that extension, C6 will move forward. C7 tends to be the last of the vertebra that will have some rotation in it, and so if you place your fingers in between the interspinous space between C7 and T1 here, and then do some rotation, you should be able to feel the differentiation between the spinous process of 7 and 1 as well. As you've identified T1, you can move out laterally and palpate the transverse process of T1. If you move a little bit further laterally, then you feel the drop-off. That drop-off indicates the transition from the vertebra itself into the first rib. So that's the vertebral and rib junction interface. So that's rib 1. Likewise, if you proceed down into the thoracic spine, you'll notice that as well. If we've identified T1, we can look at the sternal notch anteriorly, and we know that is T2 as a reference spot.
All right, so clear that out. And okay, so now let's look at our live version of that.
On our surface anatomy of our posterior cervical spine musculature, we can get a good idea of where we're dealing with posteriorly by our anterior structures. I don't necessarily do this with every patient, but it is a good frame of reference for us to utilize. So what we'll look at is our hyoid bone, our V-neck, our V-notch of the thyroid cartilage, the smooth side surfaces of the thyroid cartilage, then the cricoid cartilage, and then lastly the sternal notch. So if you come in with your patient, with your subject, and just gently place your finger and thumb underneath their mandible, you can then have them try to swallow. When they do that, you will feel the hyoid bone moving up and or down. You want to be careful. It is fragile structure, so don't try to choke your subject, but that will give you an idea here. So hyoid bone, if we look in a direction, and this line of movement is going to be slightly anterior inferior to posterior superior because of the angle of lordosis in the cervical spine. So we identify the hyoid bone right here. That will give us C3. We drop down into the V-notch of the thyroid cartilage. That will correlate to C4. We drop down laterally, and on the thyroid cartilage itself, we'll be able to feel a smooth aspect on either side. That's going to correlate to C5. We drop down a little bit further, and we're going to find a smaller but more rigid a cricoid cartilage, and that's going to correlate to C6. If we drop down a little bit further to our sternal notch, if we translate that posteriorly, that will get us to T2. Okay, so on the lateral aspect, let's talk about our landmarks. Laterally, we want to identify and palpate the mastoid process. Right there. And then as we run distally, our first lateral structure we'll come to is the lateral transverse process of C1. And it's just going to be about a finger breadth below the mastoid process. Very frequently that can be a tender location. Another important structure is the articular pillar or the laminar arch. So we'll want to identify that and its anterior-most border. And there's a reason for that. So that would comprise our laminar arch, our transverse processes on that side. As we get further into the course and talk about scalenes, other structures, this landmark will become incredibly important. So from our posterior aspect, we have several things to look at. First, we want to identify the external occipital protuberance as the skull comes up and forms the crest. It will be the most notable point right in the center. For our sake here, put a little dot there. You don't have to mark that if you don't want to. So superior to that, we have three nuchal lines. The supreme nuchal line, which is a little bit harder to palpate, but you will notice a ridge that runs across from medial to lateral. At the level of the external occipital protuberance, you will palpate, again, a line running across on either side, and that is the superior nuchal line. A little bit lower as the skull starts to dive down in towards the cervical spine itself, and this is deep and this is considerably more difficult to palpate, we'll locate the inferior nuchal line. When we deal with suboccipitals, that line becomes more important for that. But we also want to evaluate and identify our spinous processes. So we come around. C1 is almost always impossible to palpate. An extremely thin person, you may be able to palpate that, but more often C2 is going to be our first spinous process that we locate. And so what we'll do is just march our way down. C3, C4, and C5. So we've got a few more to do. What I want to do in evaluating C6, C7, T1, however, is have them do some cervical extension. When you extend the cervical spine, for people, say 40 years of age and under, C6 is going to move anteriorly. Over that age, because of degenerative processes, maybe there's some osteophytes, it doesn't tend to move quite as much, but that's what we want to look for, is a migration of C6 anteriorly. So I'm going to get my best guess of the interspinous space between C6 and C7. And I'm going to palpate onto each of those spinous processes. And so I'm going to have the subject then extend their neck, so we'll lift up, and then C6 does move anteriorly. This is easier done in the seated position. It requires less contraction of the erector spinae, the paravertebral muscles, but it still will move forward a little bit. So I know C6 and then C7 right below. So I can also evaluate C7 versus T1. C7 has a little rotation in it, so if I butt up against the spinous process, I can rotate. That spinous process is moving. If I drop down to my next, and I try to rotate here, that one does not move. So this I can identify as T1. If I move laterally off of T1, I can palpate the lateralmost border of the transverse process. I drop off of that, and then I will be dropping onto the costovertebral junction of rib 1. So here is our transverse process. Here's the first rib, and then this comprises the vertebra itself, the laminar pathway here. So I also get interested. So here's T1. We talked earlier about the sternal notch. Its posterior border would be T2. So I know we're sitting here at T1 because we did our rotation. It didn't move. That would make this T2. But I'm interested in T4 for our purposes. For this, the dry needling we'll do here. I want to find the spine of the scapula. I'll use this one over here. And so my spine of my scapula, here is my medial scapular border coming here. Okay. Spine of the scapula is going to travel along this direction. I'm going to carry that all the way to what I'll term the root of the spine of the scapula. And we can do it on each side. But basically, between T3 and T4 resides, if we draw a helper line, the spinous process of T4. So if I'm looking for T4, I find my spine of my scapula, and that gives me T4. Again, this is where we found T1 and 7. There's 2 and 3.
Okay, so for our cervical spine treatment, we will, again, our discussion, 1 finger breadth away from the spinous process, about 15 to 20 degrees angled back medially and caudally or inferiorly to reach the surface of the lamina. And so let's move on. So let's review again our 2 needling locations from our introductory material. Splenius capitis, spinalis surfaces, semispinalis capitis surfaces, and the multifidus.
The splenius capitis, the spinalis surfaces, semispinalis capitis, semispinalis surfaces, and the multifidus will all be needled in one location. The patient's going to be in the prone position. Needle length, we're going to be 30 to 50 millimeters. Backdrop will be onto the cervical lamina. So we're going to locate the spinous process of C6. It's going to move anteriorly with extension as compared to a stationary C7. Needle placement will be 1 finger breadth lateral from the spinous process of C6. Angulation will be about 15 to 20 degrees, both caudal and medial, down to the lamina as a backdrop.
And we discuss this more in the lab session themselves. Anytime we're talking about needling in the spine, we have to have respect for the lumbar lordosis, cervical lordosis, and the thoracic kyphosis. And when we talk about our angulation of our needle, our 20-degree medial and caudal, that has to be with respect to the orientation of the lamina themselves. So keeping in account where that lordosis moment or that kyphosis is, where we go into the cervical spine may look significantly different if there's a significant amount of lordosis, or if there is more of a forward head, say in an older patient. So just keep that in mind. Okay, then on the second one down lower at T4,
For splenius cervicis, the patient's going to be in a prone position. Needle length will be, again, 30 to 50 millimeters. The backdrop is going to be onto the thoracic lamina. Locate the T4 spinous process as it sits 1 to 2 finger breadths distal to the root of the spine of the scapula. Needle placement will be 1 finger breadth lateral from the spinous process of T4 in a P-A trajectory. Again, 15 to 20 degrees caudal and medial angulation down the thoracic lamina as a backdrop.
Again, with this, the thoracic kyphosis, then we're going to have a little bit different orientation when we're dealing with our 15 to 20 degree inferior angulation or caudal angulation based on the position of the lamina. Okay, then let's move into our suboccipital muscles. Here we'll look at obliquus capitis inferior, superior, and then rect cap posterior major and minor. We'll move into our three-dimensional anatomy. Again, this material is available for you on the slides, but let's start by going to the three-dimensional anatomy.
Okay, so 3D anatomy of the suboccipital muscles. 4 on each side. Here we'll look at the obliquus capitis superior, the obliquus capitis inferior, those being more on the lateral aspect. And then medially we have rectus capitis posterior major and rectus capitis posterior minor. So let's look at some of the three-dimensional aspects of these. You'll notice that they all have very similar, there's a lot of similarity in origin and attachment of these small little muscles. You can see on the spinous process of C2, we have both rectus capitis posterior major and oblique inferior, both attached to that. And then there's a common attachment of obliquus capitis inferior and obliquus capitis superior on the transverse process of C1. And then it seems, so then we have a very common line of attachment at the inferior nuchal line on the occiput. So one of the more challenging of the suboccipitals is, in reference to dry needling, is, let me bring that up, is the rectus capitis posterior minor, and goes without saying, the issue we get concerned about here is the foramen magnum. Traditionally, with dry needling, the approach is to take a posterior caudal to a posterior inferior caudal to a superior anterior approach. Well, the problem there is, again, in this general area, we can see there is the foramen magnum, and if we really want to make a good effort at hitting, especially minor, rectus capitis posterior minor, then we do have to orient our needle angulation to the foramen magnum. The problem is, well, we don't want to do that. The bigger issue is if we take too much caution in this posterior approach, then we find that we will probably more than likely land in between superior nuchal and inferior in this area, which means that we're not really hitting our target structures. So because of that, I've developed a novel approach to needling to stay away from the foramen magnum, from the brain stem, the spinal cord as it's coming inferiorly, but still making sure that we can get to those structures themselves with a slight posterior angulation. So the suboccipital muscles, they become a technical dry needling location to make sure that we do hit these, but that we also stay definitely away from our areas of concern.
So for our treatment approach here, obviously these things are very deep. There's not going to be a whole lot of surface anatomy other than being able to identify
several things. One, the spinous process of C2, transverse process of C1, and we'll also want to be able to identify the mastoid process. So let's start into our treatment lab. Again, all of this is available. Let's come down. Basically what we're going to try to do is needle at the midpoint between transverse process C1 and spinous process of C2.
In the suboccipital region, the obliquus capitis inferior. Patient's going to be in a prone position. Needle length is only going to be about 2 centimeters. Backdrop here will be the lamina of C2 or none. Precautions, greater lesser occipital nerve, the third occipital nerve, second cervical nerve, the spinal column, and the vertebral artery. Here we're going to palpate the spinous process of C2 and the transverse process of C1. At a midpoint between the two landmarks, we're going to needle in a slightly inferior angle, about 15 degrees, in a perpendicular angle relative to your palpated landmarks, which will be slightly lateral to medial onto the lamina of C2.
So up close, palpate C2, transverse process C1, and at a midpoint, we'll needle there towards the lamina of C2. Okay, that was inferior. Now let's go take a look at superior.
For the obliquus capitis superior, patients again are going to be in the prone position. Needle depth is going to be about 2 centimeters. Backdrop here is going to be the occipital bone. Precautions, the occipital artery, vertebral artery, first cervical nerve, and the suboccipital nerve. We're going to palpate the external occipital protuberance and the transverse process of C1. We're going to place the needle at the lateral half between those two landmarks and direct the needle in a slightly superior angulation of about 15 degrees toward the inferior nuchal line with a posterior to interior trajectory.
So with all of that information, what I'm going to say is it is very challenging to remember all of those directions and landmarks, especially in such an important and small space. The app comes in extremely handy so that you don't have to try to remember all of those. It's a quick reference so that you can isolate, so you can locate that very quickly and know exactly where you're headed with your needle location. Okay, and here next we'll look at rect cap, posterior major and minor. I have developed a unique way of needling those to pay respect to the foramen magnum and spinal cord as it's exiting at that location. So let's come on down. I'll talk to this in detail, but basically we'll take from inferior aspect of the mastoid process, posterior aspect of the skull, and we're going to take a midpoint here. We're going to basically end up needling at that line right below with a slightly posterior angle so that we make sure that we don't hit anywhere near the location, give or take right here, of the spinal cord coming down. So this lets us catch both needles at the same time. Needle length does have to be 3 to less than 4 centimeters, but it's a little bit longer needle to reach that.
The rectus capitis posterior major. Again, going to be in the prone position with a needle length of about 2 centimeters. Backdrop is going to be the inferior nuchal line of the occiput. Precautions, the third occipital nerve, the greater occipital nerve, suboccipital nerve, first cervical nerve, the foramen magnum, and the vertebral artery. At 1 finger breadth lateral to the spinous process of C2, we're going to needle cranially towards the inferior nuchal line in a 20 to 30 degree superior angulation, posterior to anterior with the occiput as a backdrop.
So I'm going to pause here briefly. So I'll have to update the video of the newer approach. The the representation in the app and what I just demonstrated on the slide is the way to do that. This is the older method. It is simply needling rectus, capitis, posterior, major. This one is still a good needling position if you just want to isolate that, but the other lets us get major and minor at the same time.
Caution not to needle medially.
Okay, now let's move on to our anterolateral muscles here. We're going to talk about our sternocleidomastoid and our scalenes. A note here, anterior scalene is a very technical dry needling application. I have done it 10 plus times clinically, but I found that the majority of our times it's more our middle and our posterior scalenes that are clinically more relevant. However, I do want to demonstrate the technique when we actually have lab. I will demonstrate that on a live subject. We do have to split the jugular veins in order to get to the middle scalenes, so you may choose not to if your skill level and your knowledge of your anatomy is not 100%, but I do present it for your information. So let's move on now. Again, here's the information. Let's get to our video of these. Well, first let's look at our 3D anatomy.
So let's look at the 3D anatomy of the lateral, posterolateral aspect of the cervical spine. Here we're talking about all three of the scalenes, posterior, middle, anterior, and then the sternocleidomastoid muscle. So starting with the SEM first, obviously it's got its insertion. Actually, let's talk with the origin first. This is the sternal head, and so obviously the sternal head, origin anterior surface of the manubrium of the sternum. For the clavicular head, obviously it'll be on the middle. It's about the middle third of the clavicle itself. It inserts into the mastoid process of the temporal bone. It actually has a fairly large footprint as you look around there from the mastoid process on further into the superior nuchal line. It's again a mastoid process and into the superior nuchal line of the occipital bone, with its action being flexing and laterally. It flexes and laterally flexes the neck, then rotates the head. Its innervation is through the spinal accessory nerve, cranial nerve 11. I will fade that because I want to look a little bit. Actually, let me hide that. We'll take a look now at the scalenes. Scalene is important because of their location. Anytime we're dealing with rotator cuff issues, any radiating pain from the cervical spine out towards the shoulder, get concerned about the brachial plexus as it exits over the first rib underneath the clavicle, and the role that the scalene has on that. So let's start with the posterior scalene first, and let me kind of rotate and zoom in on that. There we go. So the origin here, the posterior tubercles of the transverse processes of C4, 5, and 6, and its insertion is the external surface of the second rib. Here its action is laterally flexing the neck and then elevating the second rib, and its innervation is the anterior rami of the 4th to 6th cervical nerve, C4 through 6. We move and look at the middle scalene. So here, let me rotate. Let me fade the posterior. There we go. So we take a little bit better look at the middle scalene. Here, its origin, the transverse processes of C2 all the way to C7. Inserts into the superior surface of the first rib,
and then its action is laterally flexing the neck and elevating the first rib. So since we're here, I do want to look at, let's see, bring in, nope, wrong thing. Here we go. Do want to bring in the brachial plexus. Let's bring that down a little bit. So between the middle scalene and then the anterior scalene, we have the exit of the brachial plexus. And so just a note for self. The middle scalene, probably the most prominent with its footprint, going a little bit more superior and inferior, and with its proximity to the brachial plexus as it's wrapping around, as it's heading laterally. But finally, the anterior scalene, let me drop a little bit. So on the anterior scalene, its origin is the anterior tubercles of the transverse processes of C3, 4, 5, and 6. We also have insertion, the scalene tubercle of the first rib. So there, and then action again, it flexes, rotates laterally, flexes the neck, and it elevates the first rib. Again, it's innervated C4 through 6. So we see several locations of relevance here. I'm going to unfade that with the posterior scalenes attaching more posteriorly. We get to middle. We see the middle attaching more on just on the lateral aspect of the articular pillar, and then the anterior being more on the anterior aspect. So that would be the scalenes and the SCM, that posterolateral cervical group.
Okay, so as far as treatment, we'll start with sternocleidomastoid, and then we'll move on to our scalenes. Again, here's the information. This is what you're going to see in the app itself. But let's move on here to our video here with number 12.
For the sternocleidomastoid, the position, the patient is going to be supine with the head rotated slightly to the contralateral side. Needle length will be about 3 centimeters. There is no backdrop. Precaution here again, internal, external jugular veins. We're going to use a pincher grip, and we're going to grab the clavicular and the sternal heads of the SCM. We're going to pull it slightly away from and lateral to the neck. We're going to needle perpendicular to the fibers of the SCM in a medial to lateral, anterior to posterior direction to avoid the neurovascular structures. So go ahead and lift. Your head up again, right there, and then relax. And then down.
So here your index finger, the finger lateral is going to be your backdrop, what you're looking for. We pull away, and that way we know that we stay away from that supraclavicular triangle and all of the neurovascular bundle that sits in there. Okay, so then let's move to the lateral aspect. Here we'll actually look at the remainder of our cervical erector spiny group with the longissimus surfaces and the iliocostalis surfaces, but here we'll also needle into the middle and the posterior scalene. We're going to take a spot on the articular pillar between C4 and C5, and that gives us a nice ability to hit all of these muscles as they come and approximate onto the articular pillar, but also stay away from the brachial plexus at the same time.
For the longissimus surfaces, the iliocostalis surfaces, the middle and posterior scalene, patient's going to be positioned in the sideline position. Needle length is going to be only about 2 centimeters. The backdrop here is going to be the articular pillar of C4 and C5. So precautions here, the brachial plexus, the vertebral artery, common carotid artery, the external internal jugular vein. For this, we're going to palpate midway between the clavicle and the mandible. For the articular pillar. You should be able to differentiate between the pillar and the transverse process, which will sit more anterior. We're going to note the anterior and posterior drop off. We're going to needle at C4 or C5, direct perpendicular to the articular pillar, lateral to medial, with a 10 to 15 degree anterior to posterior angulation to avoid the brachial plexus and the vascular structures.
So patients dealing with cervical pain, especially lateral cervical pain, especially when associated with issues into and radiating down the arm on that side. The scalenes are a really good treatment choice. It's one of my more common go-to treatments, not necessarily on my first approach, but say cervical issue, I needled that C6 area, don't seem to get any response. This is probably where I'm going to move to next, but it's going to be about my evaluation and my palpation assessment to see where that tenderness lies, and if I can elicit that on that articular pillar. That, and a little bit later, levator scap is a big place that we can get some really good results from. Okay, so and then finally the technically challenging anterior scalene. So in here we have a lot of things that we get really interested in. One, external and internal jugular, the common carotid, and then the muscle, the anterior scalene, and SCM itself. So as you can see, we're going to specifically try to go and move in between our internal and external jugular vein to get to our anterior scalene. Again, if you have concern about this approach, if a patient does, stay away from it. Technically, it is a good needle. It's just clinically, we don't see as much issue with the anterior scalene as the others. But again, clinically, I have done it 10 or so times for patient symptoms. So here we're going to use our second and third fingers, and we're going to pull the clavicular border of the SCM medially about 1 finger breadth. So in this picture you can see the SCM running a little bit, and it's kind of faded, but beside or medial to the external jugular. We're basically going to just move SCM medially 1 finger breadth so that we can underlie the give us our idea where we want to have that needle location. We're going to divide the SCM into thirds at the superior margin of the distal third. So here's our first third, our second third, and our final third up to the mastoid process. At the upper margin between the first and the second third, if you will, is where our needle location is going to be. Needle is going to be partially medial, about 15 degrees to enter that target muscle, and here we are going to bisect the jugular veins. Again, if you're uncertain about your skills with this, avoid it.
For the anterior scalene, position is going to be supine with the head rotated slightly contralateral. Needle depth is only going to be 2 centimeters, less than 3 centimeters. There is no backdrop here. Precautions, important internal and external jugular veins, the common carotid artery, the brachial plexus, and the vagal nerve. We're going to use the second and third fingers. We're going to pull the clavicular border of the sternocleidomastoid medially about 1 finger breadth. We're going to divide the SCM into thirds, and at the superior margin of the distal third, at the lateral SCM border, we're going to needle in a partially medial angulation about 15 degrees to enter the target muscle, bisecting the jugular veins. Caution to avoid excessive depth due to the neurovascular structures.
So pull immediately, exposing our location, and advance just 2 centimeters, less than 3.
Okay, so now let's move over to our anterolateral muscles. Here, our upper trapezius and our levator scapulae. Upper trapezius and levator are one of our bread and butter muscles that we treat. We get a lot of good response in this at the CT junction with these two muscles. Let's come down and look at our 3D anatomy.
Okay, we're sharing here. All right, so the 3D anatomy of the posterior scapulothoracic region. Here, main thing we're going to add is the levator scapulae into what we're looking at. So let's highlight that and take a quick look at origins to transverse process of C1-2 and the posterior tubercles of transverse processes of C3 and C4. So we've got 4 locations of origin and inserts into the superior angle of the scapula, superior to the spine of the scapula. And so very common muscle structure that we see with any sort of dysfunction in that cervical thoracic, scapulothoracic, that shoulder, neck, series of problems that we deal with. But let me fade upper trap out of the way. And so it gets very technical to make sure that we needle into the levator without entering into the lung field. So it can be challenging at times to isolate that superior angle of the scapula. Could be that we need to go hand behind back, but we do need to isolate that very frequently with anything in this area. And so that's a key part to cervical dry needling.
All right, come on now. All right, so as far as the treatment approach here, let's just come and get to it.
For the upper trapezius, patient again is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. There is no backdrop. We're going to palpate for the thickest aspect of the muscle belly. We're going to grasp the muscle between the thumb posteriorly and the fingers anteriorly, at least 1 thumb breadth above the supraclavicular margin to avoid the apex of the lung. We're going to insert the needle into the muscle in a posterior to anterior trajectory using the fingers opposite the insertion point as a guide to determine needle depth.
So as far as one of the more common needlings that you will do, upper traps are just a great release. You'll probably note if you look at the research, the majority of the research that's out there, it's heavy about the upper trap. The upper trap is very prominent with the twitch or the spontaneous electrical activity. I don't advocate pistoning, as you may already know. We can drop a needle like here where we did here. We can put one on the other side, or we can put one a little bit further laterally and apply some stim and not abuse this tissue, not be traumatic to it, and simulate that twitch and still get better, the same or if not better results, simply because we didn't put undue trauma into that area. Okay, and then we'll move on to the levator. Again, here, because of its location off the superior angle of the scapula, just want to be cautious that we don't angle our needle to a location where it could enter the lung field, say between ribs 2 and 3 or 2 and 1. Now, I will apologize, the volume on this video is a little bit low, so you may find that you need to adjust your volume a little bit as this one plays.
For the levator scapulae, the patient is in the prone position, hand behind back. Needle length is about 3 centimeters. There is no backdrop. With the patient's hand behind the back, we're going to use that pincher grip to grasp the musculature at the superior angle of the scapula.
We're going to needle through the attachment onto the scapula from an inferior medial to a superior lateral direction along the plane of the rib cage, using your fingers as a backdrop.
And again, with the upper trap, so really and truly you're getting some of the upper trap here and you get a response out of there, but it usually clinically works better if you target both of these individually. So now let's move on to the temporomandibular joint. Not every clinician markets themselves as treating TMJ, and I cover a lot here, but especially something as simple as needling the temporalis and the masseter. The masseters can have a really big impact on people with TMJ if they're grinding, clenching, and so forth. So we cover that in the event that this is something that you look at. So let's move down into our 3D anatomy.
So 3D anatomy of the muscles and structures of the temporomandibular joint. The three primary that we'll deal with will be the superficial and deep masseter, and then the temporalis. But let's look at, let me kill that. Let's look at the superficial masseter first. Here we'll see, let me zoom in. So its origin is the inferior aspect of the zygomatic arch. So that's very palpable. And then it inserts into the lateral aspect of the ramus of the mandible. So there at that angle, mandibular angle, if you will. And its action is elevating the mandible, and it assists in protraction of the mandible. So it's got a little movement there. Innervation, the masseteric nerve. It's a branch of the mandibular nerve. So let's actually hide that. Oh, I have to undo that to see if I can just fade that. Okay, we've got, here we go. So look on the other side, we'll see the deep part of the masseter. You can tell it's got a very similar footprint. Inferior aspect of the zygomatic arch, a little bit more posterior than the superficial branch. Or the superficial part. Its insertion is the lateral aspect of the coronoid process in the ramus of the mandible. So it's, if we can get all the way around, that's kind of hard. So as you can see, it sits a little bit more cranial to the on the mandible itself. So we'll find that we can do some needling the superficial masseter here, and then for the deep we have to come up a little bit more cranial to make sure that we get and differentiate those two fibers. So let's come back and to this side. Let's go ahead and hide that now. So that will bring us to the temporalis. Here our origin is the temporal fossa and the temporal fascia itself. The insertion is into the coronoid process and the ramus of the mandible. And so it does extend down a little bit, but one of the bigger muscles we see dealing with clenching and so forth, temporalis, definitely a big role there. You can see with its function how it will cause the mandible, the jaw, to actually pivot through the temporomandibular joint itself. So let's go ahead and take temporalis out, and that'll give us a little bit better look for our deeper structures. Just so that we get it out of the way, let's look at the digastric, the anterior and posterior. The posterior belly of the digastric, its origin is onto the mastoid notch of the temporal bone. It attaches through this pulley, this sleeve of the hyoid bone, to then come around to the anterior belly
which it attaches to the digastric fossa of the mandible. So just below the mandible, the chin right there. There is definitely a smaller muscle, but because of their action that depresses the mandible, elevates the hyoid bone, they do play a role in the TMJ. So I do like to include those as potential causative structures. So we'll look a little bit further. Let's look at the inferior head, the lateral pterygoid. So we have inferior and the superior head. So this comprises the pterygoid. Though they are, we can needle these structures. Basically, will go in through this foramen created by the mandible and the zygomatic arch. For that, we come down a little bit lower, and for the deep head of the medial pterygoid, it can be needled from a superior aspect. I find that it's much easier, much safer to just come at it from the posterior aspect off of that angle of the mandible, and you've got a lot more surface area that you can needle into right there. We get a little bit more confined to the temporomandibular joint itself. We've got superior interior joint capsule, anterior, superior. We also have a posterior inferior joint capsule that can come into play. So in between that, let me get right back out. Then we also have the articular surfaces, but in between those, then we have the disc of the temporomandibular joint. So a lot of soft tissue in there. For us, we can needle into that articular disc, into the joint capsular anteriorly and posteriorly. Probably where we see our biggest change is in our temporalis and then our masseters as well, as far as eliciting some change. Understanding we can get to the pterygoids and the digastrics a little bit deeper if we don't see our results in these other primary structures.
So as far as treatment, let's just move straight into that. We'll start our superficial masseter, and then I'm just going to jump straight into our videos here.
For the superficial masseter position here, we're going to be in a sideline position. Needle length will be 2 centimeters with a backdrop down to the mandible. We're going to palpate the angle of the mandible and needle at 1 finger breadth cranial and 2 finger breadths anterior in a lateral to medial angulation.
So on this this needle that I'm using is a 2 centimeter needle. On some people we need just a little bit more, so a 3 centimeter may still be appropriate, but probably a 2, which is this particular needle is a I believe this one is a 0.16 diameter needle, so it's a little bit more tolerable than the 2.5 to 3 millimeter diameter. 0.2, 0.25, 0.3, not 3 millimeters. That's a big needle. Okay, so that's the superficial masseter, and then let's move into the smaller, more cranial, deep masseter.
For the deep masseter, again, position is going to be sideline. Needle length here is 2 to 3 centimeters, and the backdrop down to the mandible. We're going to needle lateral to medial at 1 finger breadth posterior, 1 finger breadth caudal from the groove of the temporal process of the zygomatic bone, inferior to the zygomatic arch. From there, we'll do the temporalis. So the masseters and the temporalis are more often than not the first and the only area that you have to treat clinically. A lot of it can really be resolved with those two. With this particular protocol, we're needling one finger breadth cranial, one finger breadth posterior, but truly this can be needled anywhere in the belly of the temporalis. I just find that this is a little bit easier with a little bit more results in this area.
For the temporalis, again, we're going to be in the sideline position using a 3 centimeter needle with a backdrop down to the temporal bone. We're going to palpate the temporal border or angle of the zygomatic bone. And we're going to needle one finger breadth superior and one finger breadth posterior to the angle in a 15-degree superior and posterior angulation.
Again, this location is where the muscle is a little bit more prominent, a little more bulky, if you will, and we seem to get a little bit more response out of that when we apply stem in this area. Can be deeper, so I did go with a 3 centimeter needle here. Okay, then to the pterygoids, we'll do the lateral and then we'll do the medial. Here you can see we're going to go through, where'd my mouse go? We're going to go through this window that we have between the jaw and the zygomatic arch to needle the lateral.
For the lateral pterygoid, position again is going to be sideline with the mouth open 2 to 3 finger breadths. The needle length is going to be 3 to 4 centimeters and there's no backdrop. We're going to palpate the inferior groove of the zygomatic arch. Just inferior to the arch, we're going to needle at the mandibular notch, lateral to medial and perpendicular for the superior head, slightly inferior for the inferior head. It may be necessary to open the mouth to increase the needle window.
And then to the medial pterygoid. So 2 different possible approaches. One, through that window we just discussed to land onto the belly of it as well, or we can take it from behind the jaw itself to land on the interior surface, if you will, of the jaw to get medial pterygoid. I find that this approach here works a little bit better. It's a little easier to make sure that I'm hitting the muscle that I'm trying to hit. And there's a posterior view of how we're trying to get to that area.
For the medial pterygoid, position again is going to be sideline with the mouth open 2 to 3 finger breadths, 2 potential needle lengths. For the superior, 4 to 5 centimeters, and then for the inferior, 2 to 3 centimeters. Backdrop here is going to be none or the posterior surface of the mandible. From superior, we're going to palpate the inferior groove of the zygomatic arch. Just inferior to the arch, we're going to needle at the mandibular notch, interior, medial, and inferior towards the rear molars. From the inferior, we're going to palpate the posterior mandibular angle from 1 finger breadth medial, needle slightly lateral and anterior onto the posterior surface of the mandible.
So we'll look at that first approach. You're going to open the mouth, open that window up, and then taking that 4 to 5 centimeter needle, we're going to needle into an inferior to get into the medial pterygoid. As an alternative, which what I tend to do a little bit more clinically, is finding that posterior angle of the mandible, and you almost have to lay that needle on the neck to needle into to land on that posterior or internal surface of the mandible itself.
Okay, then we'll look at the non-muscular pieces, the superior anterior joint capsule.
For the superior anterior joint capsule, again, the side-lying position with a 2 to 3 centimeter needle length with a backdrop onto the temporomandibular joint. We're going to palpate along the mandibular arch until you bump into the mandibular condyle. We're going to confirm the location by having the patient open and close the jaw. And we're going to needle half finger breadth anterior and inferior to the condyle in the anteroinferolateral to posterior-superomedial angle to land on the anterior superior joint capsule. Bidirectional, unidirectional rotation would be therapeutic here.
So again, palpation gets very important when we're dealing with the temporomandibular joint itself to locate that anterior, posterior, and then component, and then to find the articular disc itself. The best way to do that is just have your patient open and close their mouth and feel the differentiation there at the jaw itself. Okay, so now let's look at the articular disc, and after the articular disc, we'll move straight to the posterior piece.
For the temporomandibular joint, the articular disc, again, sideline 2 to 3 centimeter needle length, and the backdrop is into the temporomandibular joint. We're going to palpate along the mandibular arch until we bump into the mandibular condyle. Again, confirming location by having the patient open and closing the jaw. We're going to note the anterior and posterior borders of the condyle. We're going to needle lateral to medial at the midpoint of the borders to enter the area of the articular disc. Again, bidirectional or unidirectional rotation would be therapeutic here.
And then finally the inferior or posterior joint capsule.
For the inferior joint capsule, position again sideline using a 2 to 3 centimeter needle with a backdrop onto the temporomandibular joint. We'll palpate along the mandibular arch until we bump into the mandibular condyle. We're going to confirm that location by having the patient open and close the jaw, and we're going to note the anterior and posterior border of the condyle. We're going to needle lateral to medial at the posterior border of the condyle with a slight anterior angulation to the condyle to land on the posterior inferior joint capsule. Again, bidirectional or unidirectional rotation would be therapeutic here.
So on this, as you can see, you get very close to the tragus of the ear when needling this. Depending on the person's body structure, it could be a little bit more anterior. In her case, it was very close into getting real close to that tragus. All right, now we'll do the digastrics. Clinically, probably not involved that very often, but they are one of the muscles involved with mastication, so we do include that here. We'll look at both the posterior and the anterior. For the posterior digastric, the patient's going to be in the side lying position. Needle length will be 3 centimeters. The backdrop is going to be onto the temporal bone. We're going to palpate the anterior inferior aspect of the mastoid process. We'll needle from that landmark in an anterior inferior lateral to superior posterior medial angulation to land medial to the mastoid process on the temporal bone.
And straight to the anterior.
For the anterior digastric, position is going to be supine. Needle length is only 1.5 centimeters, and there's no backdrop. We're going to palpate the posterior border of the ramus of the mandible. We're going to resist opening the jaw to feel the muscle bellies just lateral from midline. One half finger breadth lateral from midline and 1 finger breadth posterior to the ramus. We're going to needle in an inferior to superior angulation.
All right, so anterior digastric, do that. Now, so that concludes our temporomandibular joint. Now we move on to the craniofacial muscles. A lot of muscles in here. Probably one of the more common things we see with this is things like Bell's palsy. We'll get to the diagnosis-specific protocols in just a little bit. But we'll start with, well, let's come all the way down and look at our 3D anatomy.
Okay, so here we are for the 3D anatomy of the craniofacial region. Bring these into play, probably more to do with Bell's palsy, things of that nature, but they can come into play at times with dealing with any sort of a facial nerve problem. There's thought of bringing trigeminal neuralgia into play. Also possibly some of the TMJ pieces, but anyway, we want to look at the different things that we've got here, and we'll just start with the big stuff and start seeing what we've got to work with here. So first off, let's look at the frontalis, or the frontal belly of the occipitofrontalis. Frontalis is the easier way. Its origin, the epicranial aponeurosis. Its insertion is the skin of the eyebrows and the root of the nose. So as we look, there's also on the posterior aspect is the occipitalis here. Its origin, the superior nuchal line of the occipital bone, inserts into epicranial aponeurosis, which that structure really and truly runs from, let's see if I can get to it. So really attaches all of this across the cranium together as one piece. Different versions of this software, different places show the occipitalis to be a little bit larger, and so this version shows it to have a smaller footprint. Either way, those muscles work to either raise the posterior aspect of the skull, or the skin of the skull, and that gets important whenever we start talking about some of our posterior perineural dry needling protocols. But let's take those. I'm going to hide those. Okay, then there's the visible. Didn't know if that was showing up. Let's see if I can highlight it. The epicranial aponeurosis. So let's go ahead and hide that. Okay, and let's try to hide that again. Okay, uncertain what's going on. We're just going to move on. So let's move to the orbicular muscles. Here, or the
orbicularis oculi. Muscles are surrounding the eye. Here, the origin is the nasal part of the frontal bone and the frontal process of the maxilla and the medial palpebral ligament. It inserts into the adjacent muscles around, and its action is just simply closing the eyes. So let's get rid of that, and we're definitely not going to needle there, so we can let's give me some attitude here. Let's move up into, let's look at the depressor and corrugator supercilii. Here the origin of the depressor is, the origin is the frontal process of the maxilla. It inserts in the skin of the eyebrow, and its action is depressing the eyebrows. I'm going to hide that. That brings us to our corrugator supercilii here, medial portion of the superciliary arch, again inserting into the skin of the eyebrow, and it draws the eyebrows inframedially. As we move more medial here, we'll get to the procerus again, just right here. Its origin is the fascia covering the nasal bone in the lateral nasal cartilage, and it inserts in the skin of the forehead. We move a little bit further distally, we'll get to the different muscles of the nasalis. So there is the transverse part, and then this should be the alar part of the nasalis. Again, any of those muscles that cause that expression, opening, closing the nares, or dilating the nostrils, is what we're looking at there. So let's move a little bit further to the orbicularis oris. Here, the origin is the modiolus of the angulus oris. It's inserts into the vermilion line and the mandible and the maxilla. And so basically its action is it compresses and protrudes the lips. It's it's the lip muscle. We look a little bit lateral, we'll get to the risorius. Here its origin is the parotid fascia, and then it inserts into the modiolus, the overlying skin of the angle of the mouth. And the action is it pulls the angle of the mouth laterally. So it's got almost a linear pull here. We look a little bit deeper, we'll get to the buccinator. And the buccinator, its origin is the alveolar process of the maxilla and the mandible and the pterygomandibular raphe. It inserts into the angle of the mouth right here, and its action is it compresses the teeth, the cheeks. There was okay, so the buccinator, here's a good reference. Compresses the cheeks against the teeth and gum. This action is used when moving food during mastication, also when expelling air from the mouth when playing a wind instrument. So it gives our mouth, our cheek, part of our embouchure, part of our, so we get the embouchure here, and we get our tightening of the lateral part of the cheeks through the buccinator. So, and now on to, we have our zygomaticus major and then minor, more medially. Their origin is off the zygomatic bone, and they insert into the angle of the mouth. The zygomaticus major a little bit further posteriorly than the minor. They both elevate the upper lip. Then we'll move on to the levator labii superioris and the levator labii superioris aliquinesi. The levator labii superioris, its origin is the infraorbital margin. For the aliquinesi, it's just a little bit more closer to the midline than the superioris itself. It inserts in the subcutaneous tissue of the upper lip, and its action is elevating and everting the upper lip. So again, all of these muscles of facial expression, there are a few a little bit smaller. We should bring out, didn't bring this into play. Inferiorly, we have the mylohyoid. Its origin is trying to get to it, look through the rib cage. So here we are looking at the inferior aspect of, there we go.
at the mylohyoid. Again, the mylohyoid line of the mandible, it inserts into the mylohyoid raphe here and into the body of the hyoid bone. Its action is elevating the floor of the mouth.
Okay, so let's let's start looking at our treatment lab approaches. We're going to start inferiorly here with our mylohyoid.
For the mylohyoid, the position of the patient is going to be supine. Here the needle length will be 2 to 3 centimeters. The needle depth is superficial. Backdrop is either none or the posterior mandibular body at the mylohyoid line. So at the anterior 1/2 of the mandible, 1 finger breadth posterior and medial to the mandible will needle superiorly and anteriorly toward the posterior mandibular body.
Okay, for ease, I don't needle with a Q-tip, obviously, just for demonstration purposes. This is the tool that I'm using in this series of videos. So we'll move from there on to occipitalis.
For the occipitalis, the position here is going to be in the prone position. Needle length is going to be 1.5 to 2 centimeters. There's no backdrop. We're going to palpate the external occipital protuberance. Then 3 finger breadths lateral and 4 finger breadths superior will grasp the muscle between the thumb and the index finger to tent the tissue. Then we're going to needle at an oblique angle into the muscle in parallel to the occipital bone.
In this area, the muscle is extremely thin, and we do have to really run almost in a tangent to the skull to enter into beneath the skin into the muscle of the occipitalis. Okay, then we'll move anteriorly to the frontalis.
For the frontalis, position here is supine. The needle length is about 1.5 to 2 centimeters. There's no backdrop. From the apex of the superior orbit, we're going to move 3 finger breadths superior. We're going to grasp that muscle between the thumb and the index finger to tent the tissue. And we're going to needle at an oblique angle into the muscle in parallel to the occipital bone.
Again, that tangential approach to get into frontalis is similar to occipitalis. Has to be very thin. Odds are you will butt up against the skull before you get superficial enough to get into that muscle. Okay, so we'll start in that medial row of the zygomaticus, major and minor, and the levator muscles more closely into the nose.
For zygomaticus major, position here, the patient can be supine or sideline. The needle length is going to be 1.5 centimeters, and the backdrop there is none. We'll palpate the inferior border of the zygomatic bone, and we're going to note where the bone moves superiorly at the level of the lateral border of the eye. 1 finger breadth caudal to the inferior zygomatic angle will place your needle, and we're going to advance it from anterior to posterior, and the muscle is superficial.
Okay, and then minor, just going to be a little bit more
toward midline than the major.
For zygomaticus minor, position here again either sideline or supine. The needle length will be about 1.5 centimeters and there's no backdrop. We're going to palpate the inferior border of the zygomatic bone, and we're going to note where the bone moves superiorly at the level of the lateral border of the eye. 1 finger breadth medial to the inferior zygomatic angle, and 1 finger breadth caudal will place the needle and advance in an A to P direction. And again, the muscle is superficial.
Well, let's come to orbicularis oculi first before we get to the levator muscles.
For the orbicularis oculi, the position is supine. Needle length is about 1.5 centimeters, and the backdrop is going to be away from the orbital border. And caution here, obviously, to avoid the eyeball. We're going to needle perpendicular to the orbital border of the eyeball, about 0.5 centimeter to 1 centimeter away from the border, most commonly at the superolateral aspect.
Again, in this regard, I'm needling perpendicular and away from the eyeball, so I find the ridge of the orbit and move away from that. You can, and then we can look at this in lab, actually thread through the orbicularis oculi, but that's something we can demonstrate again, like I said, in lab. Okay, and then, well, let's move on to procerus. We'll come back to the levator in a bit.
For the procerus, going to be in the supine position. Needle length is going to be 1.5 centimeters with no backdrop. We're going to pinch the muscle together at an upper orbital line using the thumb and index finger, and we're going to needle at an oblique inferior angle from the glabella toward the nasion.
Okay, then we'll get it's not shown here. It's faded, but here is the corrugator supercilii, and then superficial to it, that's hidden, is the depressor supercilii, and they're needled the same method.
For the corrugator, position again is supine with a 1.5 centimeter needle length with no backdrop. We're going to pinch the muscle together at the superior and medial border using the thumb and index finger, and we're going to needle at an oblique inferior and medial angle towards the nasion.
Again, this approach is used for both the depressor and the corrugator. Okay, now the levator labii superioris aliquinesi, and the next to it, the levator labii. We'll do the aliquinesi first.
For the levator labii superioris aliquinesi, the position again is supine with a 1.5 centimeter needle length with a backdrop down to the maxilla. At the level of the inferior nasal ala, 1/2 finger breadth lateral will needle in an anterior to posterior direction.
That's just adjacent to the ala. And then next to it, 1 finger breadth further lateral, the levator labii superioris.
For the
levator labii superioris, the supine position with a 1.5 centimeter needle length and the backdrop down to the maxilla. At the level of the inferior nasal ala, 1 finger breadth lateral will needle in an anterior to posterior direction down to the maxilla.
Okay, then to the nasalis. So I've included in this slide, as you can see, a lot of terms that we don't normally look at as far as being physical therapists or other practitioners, like the glabella, the nasion, the rhenion, or the ala. Probably more familiar with the philtrum, but the things like column. So I've included this diagram that indicates what these things are when we're looking at specific locations of this.
For the nasalis, supine position, again 1.5 centimeter needle length with no backdrop. Here is a very superficial needle stick. It's 1 to 2 millimeters, and we're going to needle distal to the nasal bones, along and perpendicular to the ala, and slightly lateral to the columella, mid-inferior aspect of the nares.
So nasalis, this is the place that I've selected for needling nasalis, because it does extend distally this far, but it does comprise the lateral aspects of the nose as well. It could be needled here, probably not very tolerated in this area, so we've chosen distal to that for patient comfort. Okay, and then to the orbicularis oris.
For the orbicularis oris, position is going to be supine, again a 1.5 centimeter needle length, and a backdrop is none. Here we're going to needle from distal relative to and off the vermilion border. This is a superficial muscle.
Again, similar to the orbicularis oculi, the orbicularis oris could be needled from a medial to lateral as opposed to a direct approach that we've demonstrated here. But that can be looked at in lab as well. And then risorius. Again, it's from the angle of the mouth lateral onto to pull the mouth backward or posterior.
For the risorius, the position is going to be supine with the head tilted contralaterally. The needle length is going to be 1.5 centimeters with no backdrop. From the lateral commissure, we're going to move 1 finger breadth posterior and needle perpendicular to the skin.
And finally, the buccinator.
For the buccinator, the position is going to be supine with the head tilted contralaterally. The needle length will be 1.5 centimeters, and the backdrop here is either none or the maxilla, the mandible. From the lateral commissure, move 2 finger breadths posterior and place your index finger in line with the orientation of the teeth. We're going to needle perpendicular to the skin above and below the index finger, perpendicular to the skin.
All right, so let's talk now a little bit about perineural protocols. I'm not going to have video on these. It's just about needle placement and location.
Then we'll get into our diagnosis-specific protocols. But in the cervical region, we basically are looking at our greater and lesser occipital nerve, our great auricular nerve, and our facial nerve. So why are we needling our these perineural protocols? Well, primarily what we see is sites of entrapment. And so here where my cursor is around this red dot, as this nerve comes through this fascial plane, if there is muscle tension, if there is something that's going on that's creating some tightness in that area, we can needle around it and create more movement for that nerve in that area. We also can needle for these protocols to facilitate improvement in conduction in the nerves themselves. We're not specifically targeting the nerves perineural. We're just trying to get close to or adjacent to the nerves themselves. When it comes to the soft tissue and the muscles, we're trying to target those things specifically. Let's look at the greater occipital nerve and a lot of so here there are several areas of entrapment of the occipital nerve. One is where the greater occipital nerve emerges from the dorsal C2. Start that again. Where the greater occipital nerve emerges from the C2 dorsal root ganglion, it's between the atlas and the axis. 2, between the inferior oblique and the semispinalis capitis muscles, and then 3, where the nerve pierces the semispinalis capitis. So we try to target at least 2 and 3 here. So our approach, all similar to our protocols, which we'll discuss in just a little bit. Always the first treatment approach is going to be to needle our primary locations. So treatment day 1, I'm probably going to, if we've got some paresthesia, some problems in this area, some sensory changes, some pain, maybe we're dealing with posterior headache. This is where I'm going to start with our primary neural locations. Here it's going to be occipitalis, and then it's also going to be 1 thumb breadth lateral from the external occipital protuberance, and the needle length there is going to be 1.5 centimeters. Secondary, we don't get the response we're looking for. Next time we come in, may look at our secondary approaches. Here we're going to look at our obliquus capitis inferior, our semispinalis capitis, and then our upper trapezius. If we so choose, we can go ahead here and look at our proximal spinal segmental locations. If we're dealing with nerves themselves, we always want to deal with their origin. So here it's going to be greater occipital nerve is C2. The next will be the lesser occipital nerve. Here it arises from the cervical plexus, carries fibers from the ventral ramus of C2, providing cutaneous innervation to the posterior surface of the auricle and the adjacent portion of the scalp posterior to it. So greater auricular, more over here, and then lesser on this side. Areas of entrapment here are the splenius capitis again and the sternocleidomastoid. So here our primary neural locations would be on the posterior mastoid, and would indicated right here, at the SEM insertion, and then 3 finger breadths superior, 1 finger breadth posterior from that point, and those are going to be about 1.5 centimeters needle length. Our secondary muscular locations is going to be splenius capitis and the sternocleidomastoid. Their needle length will be 3 centimeters. So on that one, we're showing this at this location. This is one that would be included in our needling at C6. Again, a spinous process of C6. Again, our proximal spinal segmental locations are going to be at C2. With these, especially when we're dealing with areas where, so here on the greater the greater occipital nerve, we had an area of entrapment coming through this fascial plane right here. A great place to utilize that unidirectional or bidirectional rotation and mobilize that tissue there just to get some room for that nerve to continue its work. The great auricular nerve is going to come around. It carries cutaneous sensory information from the skin overlying the parotid gland and the mastoid process, and the external acoustic meatus, as well as both surfaces of the outer ear to the cervical plexus and onward via the spinal nerve C2 and 3. Its sites of entrapment include the sternocleidomastoid and the mastoid process, again similar to the lesser occipital nerve. Primary location here is going to be the mastoid process, you can see here, and then superior and inferior aspects of the posterior mandible, which is less than 1 finger breadth posterior to the ear. Needle length there 1.5 centimeters. We'll also look secondary for our muscle locations, our sternocleidomastoid, and then our proximal spinal segmental locations would be at C2, C3, and there we're just looking for that multifidus, that 1 finger breadth lateral to address our spinal segmental locations. And then the facial nerve. It exits the posterior cranial fossa through the internal acoustic meatus to the facial canal, right here. It's highlighted. All of these nerves are highlighted in pink, so you can see it exiting right here. Sensory fibers here supply the interior 2/3 of the tongue and the skin of the external auditory meatus, and it also supplies the muscles of facial expression. So our primary neural locations, we're going to be less than 1 finger breadth distal to the external auditory meatus on the mandible. Will also be inferior angle of the posterior mandible, which will be where I'm at here. Will be at the midpoint of the masseter, and then the posterior aspect of the zygomatic arch. So we'll be up here. So these 4 locations, very good there. For our secondary muscular locations, we've got a plethora of muscles of facial expression that could be involved with that. So if you see one that's involved, I'd probably look at any of those that are fairly close to the motor points there for the facial nerve. So those are our 4 perineural protocols. I do use those fairly frequently. If I'm treating a patient with a problem and I treat it just dealing with muscles themselves, then I'm going to stop and I'm going to look at what our innervation is and then use a perineural protocol as well to see if we can elicit a change by using those in addition to just standard muscular dry needling. And this list here for our regional diagnosis protocols is not all inclusive. There are tons more that we can use out there. I've just brought in several that we frequently will see. One being our suboccipital headache or the migraine that tends to happen back there, our TMJ dysfunction, Bell's palsy, that upper trap tension thing that we see very commonly, any sort of cervical dysfunction, that just a generalized approach for cervical pain. We also have to look at it from a cervical thoracic junction pain if it's a little bit lower, and then we can also look at torticollis that seems to pop up from time to time. So on our regional and diagnosis protocols, they're designed to be implemented in a layered or a staged approach. Each protocol will contain, again, the primary, secondary, and usually a tertiary dry needling location. In some protocols, you may also see proximal spinal segmental locations and some distal extremity locations, as well as some periepineural locations. You want to start each protocol by treating the primary locations on day 1 of dry needling treatment. If the patient's post-treatment pain improvement is significant, which is greater than 20% improvement, then continue with treatment using that primary location and continue with those locations until patient pain complaints are eliminated or have plateaued. If there is no significant change in pain complaint after true treatment sessions, replace the primary locations with the secondary locations, or you may add it in addition to. If the patient's post-treatment pain improvement is significant, greater than 20% improvement, then you continue with treatment using the secondary locations and continue with those locations until the patient pain complaints are eliminated or have plateaued. If there is no significant change in pain complaint after 2 treatment sessions, using the secondary locations, then replace those or add into the tertiary locations. If the patient's post-treatment pain improvement is significant, which again, at least greater than 20% improvement, then continue with treatment using the tertiary locations and continue with those locations until patient pain complaints are eliminated or have plateaued. If there is still no change in pain complaint, replace tertiary locations or add onto that the proximal spinal segmental locations, the distal extremity locations, and the periepidural locations in that order. Remember that research is very strong in reducing pain and dysfunction when combining dry needling with high velocity, low amplitude thrust manipulation. It's never be opposed to adding appropriate manual therapy to the treatment approach. They frequently occur simultaneously in clinical practice. Quite honestly, it's rare for a person just to come in and be needled if there's not some other manual therapy or exercise therapy involved. Then you probably need to see if you can't brush up on some of those approaches as well. So let's start with our suboccipital headache, and here was specifically in addition with also the migraine. For the dry needling protocol here, the patient's going to be prone. Our target structures are our cervical stabilizers and the movers. Our primary locations are going to be the upper traps and our suboccipitals. Our secondary locations, let's see, I think I have, okay. So our primary locations are upper traps and occipitals. So we have our three approaches to get all four of the suboccipitals. Our secondary locations will catch the two locations from our introductory material adjacent to the spinous process of C6 and C4, and we'll go ahead and add in the levator scapula as well. Tertiary location here, we will throw in our SEM and then our middle and our posterior scalenes. For our TMJ dysfunction, our primary location, again, our target structures are muscle of mastication, and we're either supine or sideline for this. Our primary locations are going to be the superficial and the deep masseter, and then we'll add the temporalis as well. Our secondary location is going to be the lateral pterygoid, the medial pterygoid, so our lateral and our medial, then our posterior and anterior digastric. And then lastly, our tertiary locations would be the superior joint capsule, the inferior joint capsule, and then lastly the articular disc. All of these be very beneficial with electrical stimulation up to 20 minutes with a burst approach 3 hertz up to 75 to 100 hertz. Again, the reason for that is you get some of the acupuncture type of benefit of that low frequency stimulation, and then you get the added the more TENS approach with that higher frequency. With TMJ, and I'm not going to go into this because we're getting short on time, but it is here in all the slides. There is a really nice exercise prescription that I've included that covers that information. For Bell's palsy, we will look first. Our primary locations are going to be the levator labii superioris, the zygomaticus minor and major, and the rhizorius. Second, we're going to come in and we will have the levator labii superioris aliquinesi here, the orbicularis oculi, and the frontalis. And then lastly, we'll add in our corrugator and our depressor, which is the same location, our procerus right here, and then finally our buccinator. Lastly, if we're not seeing our improvement, then we can look more specifically at our facial nerve perineural protocol with the locations that we described previously. So exercise prescription. Here for Bell's palsy, here we go into much more detail on this, and here's a link to the article itself that talks about this, but some really good help. I will say, and it's anecdotally, I don't have solid research, randomized controlled trials or anything like that, but I see extremely good results, especially if we get to the Bell's palsy early. Usually 2 to 3 treatments is adequate to help that person reverse the process and start regaining control of those facial muscles. For our upper traps and tension, again, this is more that tension, that thing that we all carry up in those upper traps. Here, primary location is going to be the upper traps. Secondary, we'll throw in our levator scap coming off that superior angle of the scapula, and then finally our tertiary location would be our 2 spots from the original introductory material, adjacent to the spinous process of C6 and T4, and definitely want to stem those things. For just generalized cervical dysfunction, our primary locations, again, spinous process C6 and T4 to get the bulk of all of that posterior cervical musculature. No change there. Then we move into our secondary locations. Here we'll throw in our upper traps, our semispinalis capitis at the occipital location. Insertion. We'll hit interspinalis at C7, T1 right here, and then segmental at the spinous processes of C4 and T1 or 2T1 and any other levels as you seem necessary. Lastly, we'll bring in the levator scapula, the splenius cervicis, longissimus cervicis, the middle and most posterior scalene at the cervical articular pillar, which is this location we discussed here on the lateral aspect. For issues there, just at that CT junction as well, here our primary location is going to be the upper traps and the spinous process of C6 and T4. Our secondary will be the middle trapezius, which we haven't gotten but we'll get to, middle traps, and then segmentally at the spinous process anywhere from C5 down to T6. We'll throw in the levator scap, which you see here, and then the rhomboid minor, which you see right at the root of the spine of the scapula. And then this one is the middle trap is here. So tertiary, our lower traps, which are actually here, middle traps sitting right here. Our serratus superior posterior, which again we haven't gotten to, but we'll get to that in the thoracic piece, which is going to be right here. Our rhomboid major, serratus anterior, which will be one of these locations. Again, haven't got to that. We'll get that into advanced shoulder. We'll get that on the anterior side of the scapula, and at the same time we'll hit subscap. And then for torticollis, here our primary structure obviously is going to be the sternocleidomastoid. Our secondary location, at least the middle and posterior scalenes. We may hit the anterior as well if we're not seeing our improvement. I would probably start with just middle and posterior. And then lastly, levator scap. So that concludes all of the content for our advanced cervical. I know that's a lot of material, and we'll cover a whole lot more of that whenever we get into lab for actual demonstration and practicing that, and come with plenty of questions for that. So your post-module assignment for those who are taking this for credit and are coming for lab, your assignment is to submit a sample 3KS video that includes the following. We want to see cervical linear motion times 5 repetitions. We want to see the cervical diagonal rotation times 5 repetitions on each side, and then trunk rotation times 5 reps. And what I want you to do is submit a brief description of what your analysis is of the 3KS cervical screen. So that concludes everything here with module number 5, advanced cervical. Module number 6, which should be, if I remember right, advanced thoracic, will be in about 2 weeks. Should have this all posted and online as soon as I can get it processed. And so if you have questions, feel free to reach out to me. Otherwise, again, if you're doing this for credit, go ahead and start on your post-module assignment, and we will see you for our next advanced module.